Hello, everyone, and thank you for joining us today. My name is Gina Laundrie. I'm one of our lab genetic counselors here at PreventionGenetics, and I have the pleasure of introducing our presenter for today's webinar. The presentation will be genetic testing for kidney disorders, and it'll be presented by Dr. Wuyan Chen. Please note that we will not be taking audio questions. If you would like to submit a question, please submit it through either the Q&A or chat dialog box on the right-hand side of your screen. Please feel free to submit questions at any time. All questions will be answered during the Q&A portion of our program after the presentation. Dr. Wuyan Chen, PhD, joined PreventionGenetics in January 2013 as a human molecular geneticist. Dr. Chen's portfolio of specialties includes kidney disorders and diabetes. He also serves as the current director of the Next-Gen Sequencing Laboratory. A native of Guangdong Province in southern China, Dr. Chen received his PhD in biochemistry and molecular biology at Shanghai Jiao Tong University, Shanghai, China. And with that, I will turn it over to Dr. Chen to start today's presentation.
Hello, everyone. This is Wuyan Chen from PreventionGenetics. Thank you for joining us today. Today, I'm going to talk about genetic testing for inherited kidney disorders at PreventionGenetics. At the beginning of my presentation today, I would like to give you a brief introduction of our company. PreventionGenetics was founded in 2004. We are located in Marshfield, Wisconsin in the United States. We are accredited by CAP Clear, New York State, and ISO. We consider us as a comprehensive source for high-value clinical germline DNA testing. Currently, we offer the largest test menu options in the U.S. We are offering testing for nearly all clinical relevant genes for Mendelian disorders. Currently, our test menu including over 1,800 single gene tests, over 100 disease panel testing, and also we perform copy number testing through ACGH, MLPA, and CMA. We only accept test specimens from healthcare professionals. In addition to genetic testing, we also offer DNA banking services. Our mission is disease prevention through genetic testing. It's our mission to provide high-quality DNA testing for patients and families with an affordable price. In today's webinar, in the first part, I would like to give you a brief overview of inherited kidney disorder. In the second part of my talk, I'm going to discuss genetic testing for inherited kidney disorder by showing some interesting cases tested at PreventionGenetics. In the United States and Europe, about 60 to 80 cases per 100,000 individuals are affected by rare inherited kidney disorders. In the past years, over 160 rare inherited kidney disorders has been recognized. In the past 3 decades, over 200 costed genes has been identified to be responsible for this disease. Especially in the last decade with the next generation sequencing technology, the pace of discovery of new genes has been rapid. 10% of the adults and nearly all children who need renal replacement are diagnosed with an inherited kidney disorder. With progress to renal replacement therapy, affected individuals face a compromised health with a poor quality of life in many decades. Early onset chronic kidney disorder is defined by the presence of structural or functional defects in the kidney before age of 25 years. Early onset CKD sometimes also defined by the measurement of the glomerular filtration rate. Clinically, 4 groups of disorders together account for over 70% of early onset CKD. They are congenital anomalies of kidney and urinary tract, steroid-resistant nephrotic syndrome, chronic glomerulonephritis, and cystic apathy. In the genetic study, data show that 20% of the CKD before age of 25 years are caused by mutations in one of the 200 known positive genes. Inherited kidney disorders are caused by mutations in genes coding for a wide range of proteins, including receptors, channels, and transporters, enzymes and transcription factors, and structural components. This figure from a very nice review article shows a functional classification of rare inherited disorder of the kidney. As we can see from the functional perspective, kidney disorders majorly affect one of the 4 functional areas. These areas are glomerulus, proximal tubers, and thick ascending limb, and distal convoluted tubes, and collecting duct. At PreventionGenetics, we offer a comprehensive portfolio of genetic testing for kidney disorders. Our test menu covers nearly all known genes relevant to inherited kidney disorders. These are some examples of the disease-specific panels we offer in PreventionGenetics. Regarding the technical platforms for genetic testing for kidney disorders at PreventionGenetics, we use Sanger or next-generation sequencing for single gene testing, and we use next-generation sequencing for disease panel testing. If desired, this test can be reflected to copy number test, which is through ACGH or MLPA. Sometimes concurrent tests of sequencing and copy number can be performed. From this March, PreventionGenetics moved a big step forward to offer the custom panel service. Compared to the predefined disease-specific panels, custom panel service enable the clients to select and test for any subset of the known 3,500 clinical relevant genes for Mendelian disease. This test is an exome-based test, and therefore it has the flexibility to reflect the whole exome analysis. So in this very competitive market, what is special about kidney disease testing at PreventionGenetics? I would like to highlight some key points about our advantage for kidney disease testing. First of all, we have a comprehensive portfolio for inherited kidney disorders. Secondly, for panel testing, our gene list is very well defined to include relevant genes for panel testing. And also, we maintain frequent updates to add new published genes to our test menu. This will enable us to maximize the clinical testing and increase the mutation detecting rate. We believe too few or too many genes for panel testing is not good for the patient and the families. At this time, I also would like to highlight the importance of the Sanger component in the current germline DNA testing. Nowadays, we start to widely employ next-generation sequencing-based technology to perform DNA testing. However, for some genes in certain regions of our genome, next-generation sequencing technology currently still have some limitation for those genes. Therefore, Sanger component is still very important and essential for some genes in our genome. Also, PreventionGenetics is born as a Sanger technology-based laboratory before the advance of next-generation sequencing. Therefore, in our validation purpose, we know about individual gene very well. And also, in the genetics level, we have very specialized individual genetics to take care of individual portfolio for different types of inherited disease. In the long term, we accumulate plenty of experience for individual disease and individual genes. And we believe this experience expertise will maximize our service quality for the patient and the families. Finally, we also have excellent client service through genetic counseling and family follow-up studies and so on. And from this slide, I would like to show you some good examples and some interesting cases to demonstrate the quality and the advantage by using prevention genetics for kidney disease testing. The first group of disease I'd like to talk about is polycystic kidney disorder. As we know, also dominant polycystic kidney is the most frequent inherited renal disease and one of the most common Mendelian disorder in human beings, with the prevalence as 1 in 400 to 1 in 1,000. This means this disease approximately affects about 12 million people worldwide. About 5 to 10% of all patients who require renal replacement therapy are affected by ADPKD. Individuals who inherited and mutated PKD allele in the germline DNA will develop detectable renal cysts through ultrasound by mid-age. This disease is caused by mutations in PKD1, in PKD2, and recently the third causative gene has been discovered. In contrast, the autosomal recessive polycystic kidney disease is 20-fold less common, present primarily in infancy and childhood, and is typically more severe. Many newborn babies pass away shortly after birth. And this disease is caused by mutations in PKHD1. It has been known that about 2% of the patients with ADPKD show an early and severe phenotype that can be clinically distinguishable from recessive type of PKD. In the last decade, multiple studies have shown that bioallelic PKD1 mutations can cause early onset of PKD. Or in some rare situation, combination of mutations from different PKD relevant genes can also cause early onset PKD. This observation has been supported by evidence from mouse model studies. In prevention genetics, we have 3 disease-specific panel testing to offer for PKD testing. The first test, we offer single gene test for recessive type PKD, and in the dominant type PKD panel testing, we include 4 genes. Traditionally, HNF1B is not considered as one of the causative genes for ADPKD, but because it has evidence to show that HNF1B mutation combined with mutations from either PKD1 or PKD2 can cause early onset PKD, as shown in the previous slide. We think it's critical to include this gene in our panel testing, which will be demonstrated by the following case study. The GNAB gene is the third ADPKD gene discovered in last year. So this gene has been newly included in our panel testing. We also offer a comprehensive PKD panel to include both recessive and dominant type of PKD gene. PKD1 gene has been a very challenging gene to sequencing in our genome. The reason is that exon 1 to exon 33 of this gene has been duplicated 6 times on the same chromosome, 97 to 99% identical to the functional gene. From exon 34 to 46, this gene has a unique copy in the genome. Therefore, to overcome this issue from the homologous sequencing in this gene, multiple long-range PCR amplifiers has been employed to cover this region. And due to the same technical reason, deletion and duplication testing for this gene is performed through MLPA instead of the regular ACGH platform. From this slide, I'm going to show you 3 cases of early onset PKD with 2 notable PKD1 variants tested at PreventionGenetics. Case 1 is a fetus with severely enlarged hypoechonic kidney on ultrasound. The fetus is failed to visualize the fetal urinary bladder. And the clinical note also said the fetus has fetal microgynecia. No known family history of PKD has been reported. The client ordered PKHD1 testing first, and what we find is that only 1 VUS in this gene. There's no reflex to ACGH, and then the test directly reflects to PKD1 and PKD2 gene. What we find in this fetus is that it turns out the fetus has 2 heterozygous undocumented missense VUS. And the follow-up family study show that these 2 undocumented VUS are transmitted from 2 parents respectively. Actually, these 2 parents are only at the age of early 30s, and they have done ultrasound, and so far there's no cyst in kidney has been found. And probably these 2 VUS are the cause for the early onset of this case, but this is not conclusive. And as to the individual missense variant to the kidney phenotype in both parents is still unknown. One possibility is that these parents are still too young to develop cysts in the kidney, or these 2 variants are just hypomorphic or has incomplete penetrance. Case 2 is a newborn baby boy with echogenic bilateral kidney on ultrasound. The Neuroticism form show that this family has family history of PKD, but no genetic testing has been performed yet. The client ordered the comprehensive PKD testing panel, including all PKD relevant genes. What we find is that this boy has 2 heterozygous PKD variants. The first variant is a nonsense pathogenic variant. The second one is a well-known hypermorphic allele in the literature. So these 2 PKD variants together are probably the primary cause of early onset of PKD in this newborn baby. Case 3 is a 2-week-old boy with bilateral cysts, and the maternal side 3 generations has been known to have 7 individuals affected by AD-PKD. Therefore, the client only ordered AD-PKD gene for this patient. And the testing result turns out this boy has 2 PKD1 variants. The first one is a inflamed deletion, which has been reported to be likely pathogenic. And the second missense variant has also been reported likely pathogenic at the well-known PKD database, even though no peer-reviewed evidence has been supported pathogenicity. So again, these 2 PKD variants together could be the primary cause of the early onset PKD in this newborn. At PreventionGenetics, we have been offering PKD1 gene testing for the client for 3 years. Based on our experience in the last 3 years, we learned lessons from testing this gene for the patients. First of all, capture-based short-read next-generation sequencing technology has limitations at sequencing the gene like PKD1. Therefore, stringently and extensively validation for single sequencing is essential for PKD1 type gene. Actually, this area has represented a major technical challenge in germline DNA testing. When a solid single sequencing platform is available, it facilitates fast targeted testing family members because the vast majority of PKD1 mutations are transmitted within family. The second group of cases I'm going to present is about HNF1B associated renal disorders. One thing worth mentioning is that there's no clear genotype-phenotype correlation at the HNF1B associated kidney disorders. The HNF1B gene encodes a transcription factor, which is haptocyte nuclear factor 1 beta. The HNF1B mutations cause a multi-system disorder as shown in the left-hand side figure, which exhibits autosomal dominant inheritance. HNF1B have all kinds of mutations documented in the literature. De novo is common, and whole gene deletion is also common. It's noted that HNF1B associated renal phenotypes are very variable, which will be demonstrated by some cases in the next slides. Case 1 is a baby girl born at 37 weeks, it was reported to disease in 3 weeks. Bilateral dysplastic kidney was diagnosed at 22 weeks. No known family history of kidney disorders. The client ordered PKHD1 testing first, and the result returned as negative. And then the test was reflected to HNF1B, PKD1, and PKD2 genes. What we find is that this baby girl was heterozygous for a HNF1B nonsense mutation. Therefore, it's very likely the primary cause of the renal disease in this baby girl. Interestingly, this same nonsense variant has been reported in the literature for multi patients. This slide shows a group of 6 cases who are heterozygous for a whole HNF1B gene deletion for different medical attentions. You can see these 6 patients vary in age as of testing, and they were sent to us for testing for different panels. You can see these 6 cases, including 2 cases sent to us for PKD panel testing, 2 are for hypomagnesemia panel testing, and 1 is for MODY. The last one is a single gene test. So when the result return, they are all in common is that they are heterozygous for a similar size of whole gene deletion. Even though this has been known in the literature, whole HNF1B gene is common for this gene, but for individual cases, the result is still striking. The last group of cases I'm going to talk about is the nephrotic syndrome. So nephrotic syndrome is featured by proteinuria, hypoalbuminemia, hypolipidemia, and edema. 20% of the cases is steroid resistant, and focal segmental glomerulosclerosis is the prevalent histological feature. And the biology of this disease, podocyte is the central player in the pathogenesis of the disease, and all identified proteins and functional pathways are essential for glomerular function. At PreventionGenetics, we started to offer this panel test in 2014 with 14 genes. In the past 3 years, many new genes have been discovered to be causative for the disease. We have updated twice for this panel. Now the current panel has 44 genes to include the most updated gene list from the literature. In 2014, there's clear evidence to show that alpha syndrome genes can be mutated in patients with nephrotic syndrome clinical feature. You can see from this figure, the spectrum of the alpha syndrome is very wide. It ranges from benign familial hematuria at one extreme to early onset end-stage renal disease with hearing and eye defects at the other extreme. In particular, missense variants in COL4A3 and COL4A4 gene has been reported from different research groups to be involved in nephrotic syndrome patients. Therefore, we started to include COL4A3 and COL4A4 gene to our nephrotic syndrome testing panel. Case 1 is a 52-year-old female. No clinical notes was provided in the requisition form. The client ordered a nephrotic syndrome panel, and if it's negative, it will be reflected to COL4A5. So what we find in this patient is that the patient is heterozygous for a likely pathogenic variant affecting the glycine in COL4A3 gene. Therefore, it's likely the primary cause of the renal disease in this female patient. Case 2 is a 48-year-old female. FSGS was found at age of 36. At age of 38, the patient was also diagnosed with type 2 diabetes. The patient was sent to us to test for nephrotic syndrome panel, and reflects to delta tube is negative. What we found from the sequencing is that this patient is heterozygous for a likely pathogenic nonsense undocumented variant in COL4A4 gene. And therefore, it's also likely the primary cause of the renal disease in this patient. I'm going to wrap up my presentation today with some final words. Our own experience at PreventionGenetics and the experience from other colleagues in our community has shown that genetic testing for inherited kidney disorders have great clinical implications. First of all, the genetic testing for this disease can confirm a clinical diagnosis. And many times, it can enable the diagnosis of affected family members. And this can be very well exemplified by the PKD testing. And also, in many scenarios, it can enable precise genetic counseling for family planning. More importantly, it can reach an early detection and a treatment plan for extrarenal clinical presentations. It can also provide guidance for monitoring of potential future complications, and it avoids unnecessary diagnostic procedures, tests, and treatment. This can be exemplified by steroid-resistant nephrotic syndrome gene testing results. Finally, it can guide advanced medical management on a genetic specific basis. This is all I have today for you. Thank you for listening. The last slide shows our contact information for the company, and also we have email for general questions for our client service, and the bottom is my personal email. Thanks again for listening. Thank you.
Thank you, Dr. Chen, for your nice webinar today on inherited kidney disorders. Just a reminder for everyone who's tuning in, if you would like to submit a question, please submit it through either the Q&A or chat dialog box on the right-hand side of your screen. And with that, we'll conclude today's webinar, and we'll go ahead and read some of the different questions for Dr. Chen to answer. So it looks like our first question here that we have for you, Dr. Chen, is since the PKD1 has a highly homologous region that's performed by Sanger, is it really expensive?
I don't think so. Compared to other panels, the typical price for a regular size of disease-specific next-gen panels. I think this price, the second component didn't add much to the pricing of this panel.
Great, and I also to add to that as well too, I don't actually have the pricing information right in front of me, but we do publish our test price on our website, so our panel prices for all of our different kidney disorders that Dr. Chen talked about today are on our website as well. Another question here. Oh, and actually, we do have the PKD1 pricing. It's $1,690 for the single gene, but then we do have panel pricing that's pretty consistent and transparent. Sorry about that. Another question that came through here. Are large deletions commonly found in the PKD gene?
No. We have done quite some amount of the cell tube for the PKD genes, not only PKD1, including PKD1, PKD2, PKHD1. Deletion and duplication are relatively rare for this gene. As shown in the slides, HNF1B gene whole gene deletion is actually quite common.
Okay, it looks like we have another question here, and I think if you still have other questions, feel free to submit them, but I think we'll go ahead and use this as our last question here. The CAPKUT panel seems to be highly genetically heterogeneous. Do we see a lot of variants of uncertain significance in this panel?
That's a great question. Yes, we do. Because the interesting part about this panel is that some of the genes will only report in very limited of cases in the research community, and the association between those genes with the disease phenotype spectrum is very preliminary and it's not very well established. That's why we will see many VUS typically in those genes.
And I think with that, we'll go ahead and wrap it up. Certainly, if any other questions come about, feel free to send them to the email addresses on the screen. Otherwise, thank you for participating today and listening in on our webinar.